cute.
Oh, thank you. Thank you. But she had it really pretty yesterday.
Like the humidity on the thing got to it.
Yeah.
It's so bad.
Uh-huh.
Our kind of hair is flat. We go up.
But even after she did it, because I told her I asked, I said, do you know how to do the Dominican blowout? Yeah. But I went to the beauty school. So she said, I can only use the products that she used here. I know how to do it with what they have here. But she said, but when she passed her license and everything, get her shop, she'll know how to fully do it. So it'll last a week. I said, that's fine. That's all I need is for a week anyway, because it'll be right back up, put back in a wig. So it's okay.
I
Yeah.
was telling my granddaughter last night I need to get mine cut because it's so hot. And she goes, I'll cut it for you, Grandma.
Oh no!
She goes, all I have to do is just cut your ponytail off and it'll be just fine.
Oh no! Oh no!
I love you.
But you could just imagine how the dog looks.
Yes.
I
Yes.
said, I
That's
don't
our
think
first
so.
training. Our first training.
Yeah, the dolls. You get to cut their hair.
Be short to have a heavy.
Oh no, don't let her do it. Oh my gosh. You really have to go to the beauty shop then.
Oh yeah, I said my hair is like straight. So it's kind of difficult to cut to get it even because the more you cut it, the scissors push it away.
Oh.
Anyway, and I was trying to explain. She goes, no, all you have to do is just put a ponytail in the front right there and then just cut it off and then it'll be layered. No.
She be watching YouTube videos.
Yeah, she's watching too many
She's a
YouTube.
handful.
Oh yeah,
I know she keep you on your toes.
yeah. But we have fun with
I know. She's very outspoken.
She is.
They put them in the front ponytail in layers.
Because I've seen people try to do some bangs. They put their hair on the front and try to cut it. Some they don't come out right.
I know.
I don't know where she had to have seen that somewhere.
Yeah, probably.
I was like, oh no.
YouTube.
Yeah.
Not all the time, but like she say my bangs, they are good. Now, instead of holding, you can put a rubber band.
Yeah, that's what I was watching.
More
But
accurate. Just holding it, it's like you said, that has not been cut, the hair go out.
Right. Oh wow.
Yeah, just she want to practice. Go to the beauty shop.
Yeah.
Beauty supply. Get a wig. Get one of the clearance ones. It's like $6 and $10. Let her cut all she wants. Let her just put it on your head. Just say cut away. Just cut all you want. Cut all you want. However you want to do. Let her practice on that. They so cute.
She has braids like. Yeah, that's the first time she's gotten braids.
And she likes
She
it.
likes it, yeah. She has it real long. It's cute.
I go with African spray my hair.
They do good. Do you have like 2 or 3 at one time?
When I'm getting like the real small braids, one lady did this like 4 hours.
Okay.
Yeah, because you have some people out here break your hair. And I think they take their time, they really know what they're doing.
Yeah.
I've been doing it since I was 10.
That's good. That's good. Yeah, my niece does my hair. I don't let everybody in, but I prayed about beauty supplies with the beauty salon, beauty
school.
Beauty school.
That's where my mom goes and gets her.
Okay.
Because they only charge her
They're
like.
not expensive as the beauty.
Yeah, because she just gets them to roll it up and then she lets it dry. And I think they only charge her like $4 or $5.
Mm-hmm.
Yeah.
Yeah. Well, I wanted her to just wash and detangle my hair. And I had it in class and stuff for so long. And it took a long time. So they had to charge me extra.
Yeah.
But it's okay. I'm all right with it. What's bad? It's $25.
Oh, my God.
I paid for this test out.
Yeah, that's
Yeah.
good. Yeah, that's good.
That's what I pay for my color. But I need to redo it again. 160.
160.
See, now I go on Groupon. Groupon. It just finds a way.
No, I mean not everybody does it good. That's why I keep on
Yeah.
looking because I have one main person that
Yeah.
does it, and I'm like, okay, I'm gonna stay with
I
him.
used to be away, but
Yeah, because I remember the first time I got my hair like bleached, it was blonde all the way. I didn't want it like that, but I was, okay, it came out like that, and it looked like dirty blonde. It even looked good on me. It was ugly.
Wow.
Yeah, so that.
You could tell whoever doing it was doing it good because you could still kind of see you had like the white one.
It was dirty blonde. Supposedly it was gonna be like a beige blonde, and then went dirty blonde, and then I didn't like it. It looked ugly on me. Some colors, some blondes doesn't look good. You need to know what color goes with you.
Yeah.
Yeah. So. Yeah.
You know, I'm a New Year's baby, so.
Oh, so your birthday is January 1st?
I was almost the first, but I was like at like 2-3 minutes after. So I kind of do like a party, like not a big party, but like a family thing every year. And we kind of like do the whole New Year's thing together.
That's cool.
That is
I
nice.
would be the center of attention.
Of course. You're the big celebration. You're the big celebration. Wow. Wow, okay. Awesome. So wait a minute, your birthday is January. When is your birthday? October.
February.
February, you just had one. And you just had one.
July.
July, what day?
13th.
You just had a birthday. Happy birthday. Oh, her birthday was last Friday, y'all. We missed
Why didn't you
it.
tell us?
Yeah. Happy belated birthday. What did you do?
Because I was moving. So I had to
Oh, okay,
do
okay.
all that.
Okay, well, we got to do something. We got to do something. So we'll just have one big old party. Your birthday is in October. So we'll have something before we leave for you. And then for the rest of us that got missed or whatever, we'll all celebrate together. How about that? Okay, you guys. So let's talk about chapter 6. I like this one, like a little darker. Yeah, this one's a little darker. I like it. Okay. Procedure coding. Okay. So what book authors procedure coding? What book do you use?
The CPT.
Uh-huh. What book do you use for CPT coding? Is the CPT book. And preferably we're in 2018. And CPT means current. Uh-huh. Uh-huh. Okay. And let me ask you another question. What book do you use for diagnosis coding?
The ICD-10.
ICD-10 book. Okay, CM. Okay, International Coding. Very good. Thank you, Shaylee. Of diseases. Okay, 10th edition. Classification. What does M mean? Classification, what is that?
CM? I thought it was clinical modification.
Clinical modification, thank you. Clinical modification. Okay. Okay, fantastic. Okay, so now we're talking about chapter 6. Okay, so looking at page 152, understanding the importance of procedural coding skills. Okay, now that you've learned some terminology, medical terminology, and the basis of diagnostic coding, which was chapter 5, the next step is to learn how to code procedures. Procedure coding is the transformation of written descriptions of procedures and professional services to numeric designation. So you're turning words into numbers. Words into numbers. The physician rendering medical care, and it could be a nurse practitioner, it could be a physician assistant, it could be a physical therapist, occupational therapist, speech therapist. Um, they either write or dictate this information in the patient's record health. Then the insurance billing specialist reads the pertinent information and verifies this with the procedure codes marked on the encounter form. We're going to look at that in your workbook. Routine office visits and procedures usually are listed with codes and brief descriptions on the encounter form. These services are documented in the record and circled or checked off on the encounter form by the physician when they are performed during the patient's visit. Now, encounter forms, let me explain what that is. Okay, so right, look. Encounter forms in a doctor's office are forms used to mark off, to mark or circle the treatment of care and the diagnosed number sometimes given to the patient to give to the front desk clerk to receive and process for payment from the patient and bill to the insurance. By the biller. Okay, now, an encounter form can also be a super bill. Okay, can also be a super bill. And it has to be written in such a way that CMS can read and accept in lieu of a CMS 1500 form. The encounter form must be approved for use from CMS. Okay, from CMS. Okay, now I'm gonna it's like a replacement. Okay, it's like a replacement. But it's more specified to that provider. Okay, so what the provider does, they can go and write up one, or they can find a template of one, and long as it's written in such a way where the insurance companies can read it and process the claim the same. Okay, now this is back in the day when this is paper billing. Okay, when you did paper billing. Now they also, may use a super bill electronically. Okay, when you're doing Medisoft, but 9 times out of 10, a majority of your medical billing software use a typical CMS 1500. Okay, on there. But in case you all work at a provider's office and you're wondering, you say, this don't look like a CMS 1500. Well, we use that. Are you sure? Yes, they do use that. Okay, so all what it does, it has procedure codes that are pertinent to that provider's office. Okay, so if family practice doctor sees a lot of hay fever patients, they already have that procedure code on there. All they got to do is mark it. If all three evaluation management codes are listed on there, then all they got to do is mark an X by a designated one. If they do certain labs in the medical office on a routine, then all they got to do is mark an X. There's really, it's a shortcut to keep you from looking in the CPT book, and it just kind of helps you. Now, I'm not saying you don't ever need to use your CPT book or your ICD-10 book, but this kind of helps shortcut things and help you work in a much faster and efficient pace. Does that make it clear? Now, they do have certain areas where it's left blank and you may have to write in a procedure code that's not normally seen routine every day in a doctor's office. And that's what a super bill will allow a biller and a coder to do. Okay? So just know that when you all get ready to do billing and you see a super bill in that position using a super bill, it's okay, don't panic. Okay? It's okay, don't panic. All right. Because like I said, you still have some physicians, offices, practices. I know my endocrinologist, one, God knows I love them. They still live in a dinosaur age.
In the hospital,
they don't use the super bill.
Yeah, they're up to date.
They're up to date. That's right. Yeah. Hospitals are more well suited on their billing, and they're straightforward on what billing form they use. They're straightforward on that. Yeah. It's only physician offices that will use a CMS 1500, or on occasions you will find a super bill. If you Google what a super bill looks like, or a super bill form, then it'll show you some examples of what a super bill form looks like. so you can be familiar with it. And we might play around with that today. Okay. Okay. With the implementation of computer technology and stricter adherence to federal regulations, more emphasis is being placed on correct procedure coding. Coding must be correct if claims are to be paid promptly and optimally. Every procedure service must be assigned correct and complete code numbers. Because of the complexity of procedure coding, a working knowledge of medical terminology, including anatomy and physiology, is essential. So you all have been learning that medical terminology in your chapter books and anatomy and physiology. Okay, the body organs and structures and the different sides and everything. Procedure codes are standard methods used to precisely describe the services provided by physicians and allied health professionals, such as chiropractors and nurse practitioners. They also allow claim forms to be optically scanned by insurance companies. The general acceptance of codes by third-party payers and government agencies assures the physician who uses standardized coding systems that the services and procedures he or she performs can be objectively identified and priced. The American Hospital Association and the American Health Information Management Association guidelines for outpatient services and procedure coding and reporting requirements for physician billing may be found by visiting their respective websites. The AAH Central Office is the official clearinghouse for information of proper use of the ICD-9, ICD-10 codes, Level 1 HCPCS codes, and hospital providers, and certain Level 2 HCPCS codes for hospitals, physicians, and other healthcare professionals. In addition, CPT Assistant, the published American Medical Association, gives guidelines for outpatient services and procedure coding. The primary coding system used for physician offices for professional services and procedures are called the current procedural terminology and published and updated annually by the American Medical Association. Okay, so let's write that down. Okay, CPT books are authored by AMA, American Medical Association. American Medical Association. Okay? ICD 10 books, CM, are authored by World Health Organization. Okay? To obtain a current copy of CPT, visit the AMA's website. A relative value scale called Relative Value Studies is also used for services and procedures. It is a system by Medicare called Resource Based Related Value Scale, so the RBVS, RBS or RBVS. Provide unit values for CPT codes that can be converted into dollars by use of geographic and conversion factors. Okay, so they're the ones that make the calculation. Okay. All right. Okay. Centers for Medicare, Medicaid Services. They're the ones that father Healthcare Financing Administration. Healthcare Financing Administration used the RVS, or what we used to say the RVDS. They kind of changed it up a bit. But again, let me give you a prime example. And then we'll look at some calculations. If they calculate 99201 to be $100, 99202 to be $150, 99203 to be $200, 99204 to be $250. It is like that in all 52 United States of America. Okay, anywhere you go. It's against the law. They cannot upcode, they cannot up the charges any more than whatever that assigned code is. They cannot go any lower than that assigned code is. Okay, unless they, work out a payment plan and you're a fee-for-service patient. That's something a little different. Okay, now I'm going to circle these on the end for you. These right here represent the level of care. Okay, the level of care. Okay, we'll get to talking about that. And time spent. With the patient. Okay, and then we're going to look at the CPT books once I get there, but I think they have some examples in here. This is when you spend 10 to 15 minutes. This is where you spend 15 to 20 or 25 minutes. This is where you spend 20 to 30 minutes. This is where you spend 30 to 45 minutes with the patient. Okay? Always pay attention to the last 5th digit of that CPT procedure code. That's going to tell you what level of care was done. Some of it is just straightforward. Some of it is detailed, a little bit more detailed, very much detailed. Details meaning that it goes accordingly. If they had to do a lab work on you and give you some results and you have to sit there more than 15 minutes, then yes, we're going to give you that. If we had to do a lab work and we had to do maybe an ultrasound in the office, okay, then we're going to charge you $99203. It depends on how much work was done. If it's 1 or 2 labs, if it's a lab and a radiology, then that's going to be between the 3 and the 4 levels of care. If it's just a lab and an office visit, that's going to be between 1 and 2. Does everybody get that? And you're going to learn about the variables of coding, because in the CPT book they have straightforward, high complexity, low complexity, moderate, the different variables. If you find if it's 4 variables listed and you find that 3 out of the 4 variables from that SOAP notes, where do we live in the SOAP notes, medical bills? Assessment, thank you. We live in the assessment part of the SOAP notes. If we find, and I'm going to teach you how to abstract that information. If you happen to find 3 or 4 different variables, you're going to know how to pick what procedure code. It's not hard, it's very easy. Once it just looks that way, it may appear to be that way, but once you start practicing, it's very easy, very easy. Okay? And sometimes the doctor will help you out when he'll say 15, or he'll say 10, or he'll say 25. And that's a clue right there for you. Oh, it's this, that, or the other. Are y'all getting that? Okay? So it's not hard at all. Once you get to it, you pretty much know, oh yeah, I know what that is. I know what that is, yeah. Okay? Some managed care plans develop a few internal codes for use by the plan only. Sometimes the codes are used for tracking. Other times they're used to provide reimbursement for services not defined by CPT on the basis of their benefit structure and internal need. Okay, so current procedural terminology. The first edition of the physician's current procedural terminology appeared in 1966, and it was subsequently revised in 1970, 73, and 77. Since 1984, CPT 4th edition has been updated and revised annually. The code numbers are added or deleted for new procedures or developed, or existing procedures have been modified. These changes are shown in addition by the use of symbols, which are described and shown later in this chapter, figure 6-4. We'll look at that. The symbols with their meanings are located at the bottom of each page of the code numbers of the CPT book. Just like when you look at the ICD-10, and I described to y'all, if it has a red dot by the ICD-10, that lets you know it needs a 4th digit or a 5th digit. It just depends. They have symbols too. Well, the same thing for the CPT book. It has symbols too. Are y'all getting that? So remember, like I told you when I was teaching kindergarten, you have to go through the book from the cover, from the first page, second page, page by page, page by page, page by page. Okay, so you can read all the coding guidelines in that book, what all the symbols are for in that book. The modifiers are used to give an adjective or an accent to the procedure code to tell you why they're using this procedure code. Why are we using a 99204 on the first line and a 99204 again on line 4 with a modifier 25? Is because that patient was in the office 9 o'clock this morning. We did a stool culture or we did some sort of lab sample, and we need that patient to come back for the results because we ordered a stat result for that particular lab. So now you're not charging the insurance company just one fee for that day. You're charging them because that patient was seen for that first time being seen, and they're being seen again for further evaluation. So you have to charge for that doctor's time, okay? You have to charge. That's why you use a modifier 25. Now, if you don't use a modifier 25, but you are using CPT code, let's say for example, 99204, and you put it on line 1 and you put it again on line 4, and you don't put a modifier by the second time you put in the 99204, it's going to get rejected. It's going to get rejected saying, we've already paid you for one office visit, why are we paying you again? So now what you have to do is appeal and say, excuse me, Cigna, excuse me, United Health. The reason why we're charging this again is because the patient we ask the patient to come back to the office. Here's a copy of their SOAP note for this particular date of service to give reason why. And these are the labs that we ordered. Here's proof of our work. So could you please reprocess our claim and pay us? When they reprocess their claim, then the claim will be paid. Again, I think I said this before. Let me write in purple. Okay. Now. Okay. Now. 3 results that come back from an insurance agency with an EOB. Okay. Will either, that's an E, y'all, I'm sorry, will either be what? Pay, pin, or deny. Very good, Ebony. Very good. Pay, pin, or deny. Okay. And then to understand the interpretation of the EOB, the edit message will further explain why. Okay, remember I told you edit messages are what? Are your friend. Edit messages are your friend. So if you get 5, let's see, you get an EOB from an insurance company to a provider office. The EOB that's sent to a doctor's office is written same or similar the way they would write an EOB to a patient. When they write an EOB to a patient, it's strictly for that patient. When they send providers EOBs, it has list of patients and maybe a check attached at the end. Are y'all getting that? Okay. Now, if you get edit messages, let's suppose you have Cigna, you have Aetna, you have United Health, you have Marina Healthcare, and you have Humana. And let's suppose you have so many that says denied for eligibility from this insurance company, that insurance company, this insurance company, that insurance company, this insurance company. But they all denied for, what is it?
For the same thing.
For the same thing. Very good. You got it. You heard me last night. Very good. You're going to put those in a what? Stack. Then you're going to go back through, you're going to go through your edit messages. You're going to find another set that all read the same thing. Okay. This was denied for eligibility. Okay. These are going to be denied for pending medical records for whatever reason. So you're getting a whole bunch of stacks from 5 or 6 different companies. You're going to put that stack together. Then you're going to have some that's going to be stacks for coordination of benefits. Okay. Because you need to ask the parents, secondary insurance, or we need this information, or they need proof, or they need proof that the child is a full-time student because they 19 years old, and they have coverage up until the age of what?
26.
26. If they are a what? Student. Used to be the age 21. Now they done moved it up a bit because they figure it takes kids these days a little longer to get their degrees. Okay, So you put that stack. Once you put all those same similar stacks together, doesn't matter what insurance company they come from. I will put all the insurance company together for Aetna on top of this, all of it from this insurance company, and that way you have a neat stack. So once you need to call the insurance company, you got all the 5 or 6 in here you can just handle in one phone call. Y'all get that? Now, you might have some customer service reps, they might be mean, or you can kind of tell in their tone, they mean mugging you. They ain't gonna give you no more time, but for one patient. Then you have some, they know how to work the system, work their job, and they say, okay, well, all right, and you might say, hold up, I got 3 more that I need to verify. Can you help me out with those 3? Or I got 3 more, I gotta ask questions. They know how to do their job, they know how to work the work and to help you get your work done. So now what have you done? You have organized your work and you know how to what? Work efficiently, right? So you're making good use of your time. You're going to utilize maybe 2 or 3 hours of your day. Everybody, if you're working a typical 40-hour week, that's what? 8 hours a day. Okay, minus your lunch. Okay, so that means you're going to make good use of your time. You're not going to have time for too much of anything else, office politics and water cooler conversations and sitting on Snapchat and Instagram and twit and all this here stuff, Facebook and all this here stuff. You too busy, you know, unless it's kids or something, that's something different. That's something different, okay? But your time should be what? Well spent. Well spent. Okay, all right. That makes you a valuable person. That makes you constantly employable, and it makes you work your salt. You getting confidence. It makes you work your salt. You're going to understand the value of who you are, and you're going to get them to understand the value of how they need to perceive and see you. Okay, but when you get ready to make the moves, baby, what chicks say? Money moves. When y'all get ready to make them money. Yeah, I be hearing what the young folks be listening. When she get ready to make them money moves, you're going to know how to make them money move. You're going to know how to get promoted. You're going to know how to do what you need to do. Okay? Because you're going to know your what? Your worth. Your value. Okay? All right. So let's move. Hold on. Let's see. Yeah, my husband, we were watching her on Jimmy Kimmel. My husband said, wow, she had on pink. All this pink feather, something she had on. He said, I like that money move. But some of this, he was like, ooh, that's a little too deep. But he liked the main part where she was saying money moves. He liked money moves. I said, yeah, we got money moves. Yeah. That part we liked. Everything was like, I love it though, but that was a bit too good. Okay. Okay, so skipping around along, blah, 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 procedure code numbers. I'm on page 153. Where it says procedure code numbers represent diagnostic and therapeutic services or medical billing statements and insurance forms. Okay. Blah, 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 blah. Okay. All right, so let's go to page 154. 154. Okay. Level 2, Hicks-Picks National Code content. Okay, so Hicks-Picks codes are a little bit different from your typical CPT codes, okay? CPT codes have 5 digits. 5 number digits. Okay? Now, Hicks-Picks codes have a letter, and 4 number code, or four number digits. Okay, 4 number digits. 4 number digits. Okay. All right. So let's look at this. Prime example, A. You have transportation services, including ambulance, medical and surgical supplies, administrative and miscellaneous and investigational services and supplies. Those code ranges are A 0000 to A 9999. Do y'all see that? Okay, so if y'all see any HCPCS codes that begin with A, they're procedure codes for ambulance services. Some of y'all might be interested in becoming medical billers for ambulance services, okay? Or for the city of Houston to bill for their ambulance services for the Houston Fire Department, okay? All right. B codes are eternal and paternal therapy, okay? Eternal, like your feedings, okay? Like IV feedings. What do you call that? Ensure. What's another? Ensure. I don't know about Atkins or anything like that. But y'all have an idea what I'm talking about, right? They're in the little cans.
Oh, like Boost.
Boost. There you go. Boost, Ensure. Okay, those internal feedings. Okay, and home health agencies would deliver those, and doctors would prescribe those for patients, and the insurance companies would pay for that under home health. Okay, and they have to have so many feedings of that per day for nutritional reasons. Maybe they're underweight. Maybe they have to maintain a certain weight. Maybe liquid feedings is about all that they can handle, depending on their illnesses or their diseases. Okay, especially with ALS patients, God bless their hearts. And so they have to have maybe 8 cans a day. So if you do 8 cans a day, 7 days a week, that's a lot of cans. And so when I did home health billing for Memorial Hermann, they would bring like stacks and stacks and stacks and stacks of that to feed patients like that. Okay, so you would have to use those B codes. Are y'all getting that? Okay. C codes, temporary codes for hospital outpatient prospective payment systems. Okay. And we'll talk about what that is a little bit later. D, dental procedures, diagnostic, preventive, restorative, endodontic, periodontic, different things like that. These codes have been removed from the HCPCS list, but remain available from and maintained by the American Dental Association. Okay, now there are some cases where if a person suffers from esophageal cancer or some sort of tongue cancer or nasal cancer or brain cancer, they've had so much radiation, things of that nature, and their teeth have fallen out from radiation and chemotherapy. And I've known some patients for that to happen. Sometimes for cosmetic reasons, they can have those implants done and covered at the expense of the medical insurance. And how do we advocate for the patient to get that covered if they're cancer patients of that nature or patients of that medical necessity? Oh, y'all are music to my ears. Y'all make me so proud. Thank you, thank you, thank you. Oh my goodness, thank you, hallelujah. Okay, so you can use those HCPCS codes and write a letter of medical necessity and say, this is also going to be covered under dental. However, we want to first cover this under medical because the patient was diagnosed with esophageal cancer or some sort of head cancer that has affected their dental work or their dental being. Okay, and we want to replace or help restore whatever that is. Okay, and you work together. You'll be amazed how many dental offices can make a lot more money if they knew how to do that. Okay, you would be amazed. Once you all learn how to write these medical necessities, you can go out and say, can we kind of help consult and look at some of your patient records and blah, 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 blah. I might do that as a project. And see how can we help get some of this other stuff paid, because some of it is due to chemotherapy. Chemotherapy dries a person's mouth out. Certain medicines dries a person's mouth out. You can get that covered based on what? Medical necessity. And it can be paid what? On the medical side of insurance. Dental insurance it covers, but it doesn't cover enough. And yet you still fall in the expense of paying a lot out of your pocket. Okay. I still to this day do not understand why insurance companies don't cover as much or enough as your typical medical insurance would. They should. Your teeth, your mouth is the first line of defense. It is the first thing that makes all the difference of how your body functions. If you don't, you have to chew 25 times before you swallow. The mastication process is 25 times, meaning all your enzymes, your salivary glands, everything should be moist and getting whatever you've eaten well chewed and devoured before you swallow. So when it goes into your stomach and the enzymes in there and the gastric juices in there is supposed to help work and push and process that up into the ileum and the jejunum all the way out through the small intestine into the large intestine out the other end. If this is not processed properly in your mouth, if the care of your mouth is not well taken care of, it affects everything else here. That's why I talked to one of my colleagues. He's a dentist. God bless him. I love both of them. We were just talking about that. And I said, what can I do in Congress to get them to change how they cover for dental work? Because, oh my God, it's expensive. It's ridiculous. He said, Ms. Harper, I don't know. I said, well, I'm going to figure it out. And when I figure it out, you ready to come on board? He said, yeah. I said, okay. Because I'll fight with you. I'll fight, buddy. You know, I don't know. It's just a travesty to me. I don't understand it. But I think I'm not discounting dentists at all. Dentists are well-needed professionals. We need them. It's how we survive with our teeth. Okay. And nowadays they fix it to where you don't get your DDS. Now you're MD. DDS. Yeah. You a medical doctor / dentist now. Yeah, they didn't upgrade that, just like they did pharmacy. You Form D now. You're not just registered pharmacist with a master's. You Form D with a registered PhD. Okay, so that's good. I just think if you're going to upgrade the education, I think you need to upgrade the coaches. That's just my personal opinion. Okay. Now let's look at E. E is for durable medical equipment. We talked about that the other day. Canes, crutches, walkers, commodes, decubitus care, bath and toilet aids, hospital beds, oxygen, related respiratory equipment, the CPAP machine me and Tony talked about yesterday, monitoring equipment, pacemakers, patient lifts, the Hoyer lifts when patients are too heavy to lift out of bed or turn over, safety equipment, restraints, traction equipment, fraction frames, wheelchair, artificial kidney machines, such as your dialysis machines, okay? We have to use the E codes. That's what the E codes are for, okay? How many of y'all would like to do billing for a home health agency? No, it's not a lot at all.
Office, it depends on which company you work for. Okay.
As long as it's night shift, I'll take anything.
If it's night shift, you'll take it? Yeah. Sometimes you can do billing from home, and it's not hard at all. I know. I saw you were like, no, my baby be sent to school. You know, and I understand. I really like it. It's very easy. The only difference is that when you do internal feedings or wheelchairs and stuff like that, you have to make sure that you get referrals from the doctor's offices for them to cover for those things. And it's not hard at all. It's just gathering paperwork and billing. That's it. So instead of you being the biller and the coder, but it's all about getting paper trail of work, together. And it's not hard at all. Or getting pre-certs or authorization numbers. Sometimes you have to call the doctor's offices and say, it's okay, this person is down to their last feeding, last sense of feeding. I need y'all to send me an authorization. And then sometimes you may have to send a visiting nurse, registered nurse, or an LVN or someone to update their care, to document how they're doing. Are they doing okay? Are they gaining weight? They have to make those home health visits. And then when they do make those home health visits, okay, then they send the information over to the doctor's office, and the doctor's office can check off and say, okay, we're going to give you another referral for so many months for y'all to keep supplying to the patient. It's just a routine. It's just a little different from your office billing and coding. Yes.
Do you have, because you'll be that biller for that home health care service.
Mm-hmm.
Do you do all of the patients, or do they assign, or you don't?
They assign you patients.
Okay.
They assign you patients. Yeah.
So it's not as like the hospital.
Right.
Tons of people.
Right.
Okay.
Right. It's not tons of people. So say, prime example, you work at Walgreens, right?
Mm-hmm.
Okay. Walgreens has a home health agency. They do.
Yes, we started seeing patients. We just started like last week. But we started instead of certain patients that can't come pick them up, I guess Medicaid or something is covering it.
Yes.
We send it out to their homes.
Yes.
We send them out the medication.
Yes. So you can work in that aspect, home health division, and they supply wheelchairs and eternal feedings and things of that nature.
And do you constantly bill for that?
Yes, to the insurance company. Yes.
Okay.
Mm-hmm. They even have billing for pharmacies, where you do nothing but billing for them. That's what the part of what the pharmacy techs do. But sometimes the pharmacy techs get so busy filling the prescriptions along with the pharmacists, or giving them out, or getting refills and stuff like that. Sometimes they need a separate person to do nothing but straight up billing, especially if you're working for a compound pharmacy, where they do pharmacy a little bit different than your retail pharmacy. Your retail pharmacy like Walgreens, CVS, HEB, Kroger's, those are retail pharmacy. Your compound pharmacy, they're the ones that actually make the drugs there, okay, that normal retail pharmacies don't do or make. Does that make sense?
Mm-hmm.
And sometimes they need billers to do billing for them too. Okay, so just kind of keep your mind open for that.
You see everything. You say, I feel like, I don't know. I'm just.
No, what I'm saying, I think you have a great advantage right there where you are if you're open to it, and just say, y'all billing this to the insurance company or da 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 da, and then you might get to talking to some of the billing people. I think it's called I think Walgreens Home Health is called Apria. I could be wrong, but that was our competitor when I worked at Lamar Herman. It's called Apria. I think it's still called Apria, but ask your manager about that. And you may want to ask them, and you may want to do some of the billing for them. And sometimes if you're friendly enough with the pharmacist, you may want to ask them, hey, can I learn how y'all do y'all billing? Do y'all need somebody to just sit there and just straight up do your billing? I'm learning how to do this. You all, when y'all get through, you all will be able and foundationally knowledgeable. I'm not saying 100% knowledgeable, foundationally knowledgeable to do billing for any and everywhere, as long as it's medical related. Okay? Now, if you have any questions about, if you're not sure how the processes go, then that's what I'm here for. Okay? Like I said, I'm not just your teacher, I'm your mentor for life. Okay? So whatever you don't know, ask me. I will find the answer. If I don't know, I will find it. I will find it and get it to you. Okay? All right. So, very good. Let's keep moving. Blah, blah, blah. Okay. E codes. So let's look at G codes. Procedures, And professional services, temporary under review for inclusion in the CPT book. Okay, so we'll come back to that. H codes. H codes are for alcohol and drug abuse treatment services. Okay, that's those alcohol and drug abuse centers. Okay, those rehab centers that you can bill for. Okay. J are for drugs administered other than oral method, like chemotherapy drugs, immunosuppressive drugs, inhalant solutions, miscellaneous drugs and solutions. Okay, those are drugs. Sometimes those are like your injections too. Okay, that kids get those shots, those what do you call that? Vaccines. Okay. K, temporary codes for durable medical equipment and drugs. These codes are approved for permanent inclusion of HCPCS. They can become A, E, or J codes. L, orthotic procedures and devices, prosthetic devices for scoliosis equipment, orthopedic shoes, and prosthetic implants. Okay, those are the patients that have prosthetic hands or prosthetic limbs. Okay, different apparatus that helps them move and get around. Okay. Orthopedic shoes. Some folks have one leg shorter than the other, and they have to get a prescription for it. Okay. Insurance will cover for that. Okay. P codes for pathology and laboratory services. Okay. These are pathology laboratory services that do a much greater work than what LabCorp or Quest Diagnostics do. Okay, these are your more unusual pathology type work. Okay, and for you lab techies here, you're gonna find that out. Okay, well, you pretty much already know, but you're gonna find that out more so. Okay, have y'all ever had to do any unusual lab work?
No, because where I worked was pretty much a well-woman facility.
Okay.
So, but I mean, I know what you're talking about because, like a liver biopsy, that wouldn't be something that I would see. But
right, that's unusual.
That would be unusual.
Exactly. Okay, then you have your Q codes, which are miscellaneous temporary codes, your R codes, diagnostic related codes. That would be more or less like your radiation, things of that nature. Okay, your S codes, temporary national codes for level 3. They've been phased out. Sometimes they'll phase out certain codes. Sometimes they'll bring certain codes back. Okay, and those are called trending. So what it is that they may figure, oh, this is a procedure that we're no longer doing, so we're not using those procedure codes anymore because this procedure has been outdated. Okay, and then they may find out, you know what, this was successful, and they'll find out 5 years ago. Let's go back to that. Okay, so we bring it back to S. It's just crazy. That's why they update the CPT book and the ICD books every year for that reason, because of trends, what worked and what may not work. Okay. T codes. T codes are established for Medicaid agencies and not valid for Medicare. B codes. B codes are for vision, hearing, speech, language pathology services. Okay. So if you have a speech pathologist or an audiologist or maybe someone that's dealing with Braille, dealing with the blind in some aspects for some therapy, they will use the B codes. Okay. Alternative billing codes, ABCs, were created and distributed by Alternative Link and approved for a pilot study. They are 5-character alphabetic symbols with appended 2-character practitioner modifiers that represent the practitioner type. Healthcare products and services. Integrative healthcare is that incorporate the best approaches for conventional and complementary and alternative medicine. Okay, these are very rare in use, so we're going to kind of skip around in that. But just know that it is there, and if you need more information on it later on, you can always ask about it. Let's go to page 155, where it says methods of payment. Private insurance companies, as well as federal and state programs, adopt different methods for establishing payment rates for outpatient services. You have fee schedules, you have usual, customary, and reasonable, UCR. You're going to always hear that when you call an insurance company to verify benefits, okay? And they're going to say usual and customary, or usual, reasonable, and customary. You're going to always hear that lingo. And relative value scales and schedules. Additional methods of payment for inpatient hospital claims are discussed in Chapter 17. Fee schedule. A fee schedule is simply a list of accepted charges or established allowances for specific medical procedures. A medical practice can have more than one fee schedule unless specific state laws restrict this practice. Charges refer to the regular rates established by the provider for services are rendered to both Medicare beneficiaries and other paying patients. Charges should be related consistently to the cost of the service and uniformly applied to all patients, whether inpatient or outpatient. The following situations can occur. Providers participating in Medicare program would be typically paid by fiscal agent an amount of the fee schedule for Medicare patients. Providers not participating, so we're going to talk about par and non-par providers, okay? So you may want to highlight that, participating and non-participating. Make a note on top of that where it says participating and put that as par providers, P-A-R, par providers. Put in parentheses next to that and put contracted. Par providers are contracted providers, and we'll talk about that. Non-par providers are non-contracted providers, okay? And we're going to talk about that. And they will be paid by the fiscal agent an amount based on the limiting charges for each services set by the Medicare program. Like I said before, CMS fathers Healthcare Financing Administration, in which Healthcare Financing Administration write out the calculations for the RVRVS for every procedure code that is used in the CPT book within the how many United States of America? 52 United States. That includes the Virgin Islands and Puerto Rico. Okay? All right. Providers having contractual arrangements with a managed care plan. So, for example, health maintenance organization, individual association, or preferred provider organization will be paid on the basis of the fee schedule written into the negotiated contract. Providers rendering services to those who sustain industrial injuries use separate workers' compensation fee schedule, okay? And that's going to be found in Chapter 15. So that's why I told you I want to use the rest of the days a little bit more lengthy to completely go through the Fordney book. You all need to know that. I have a feeling somebody is going to need to know workers' comp and know how to type all that. Yeah. Okay. Now, moving on to page 156. Usual, customary, and reasonable. So, for examples of the cases here. Okay, so we have a surgeon's bill. For examples of the cases. So, usual, customary, and reasonable is a complex system in which 3 fees are considered in calculation of payment. The UCR is used mostly in reference to fee-for-service reimbursement. So let's look at this, for example. A surgeon's bill is $400, okay, for whatever that procedure was. The usual fee to pay would be $350, compared to customary $350 across the board. Declared reasonable and extenuating circumstances, payment can be paid up to $400. Okay, let's look at this. A second situation, $400 for a different type of surgery. The usual fee schedule payment would be $350. Okay, the customary fee schedule across the board commonly pays $350. A declared customary no unusual circumstances pay for $350. So if it's unusual circumstances, it's because maybe they had to have an assistant surgeon, okay? And you're using a modifier 80. We're gonna look at that, modifier 80. Modifier 80 says that the surgeon did the surgery, maybe the first half, the physician assistant, or the surgeon the second surgeon, which assisted in the surgery, had to do the second half to give the doctor rest from the first half. You ever notice on those TV shows how they have like 3 and 4 surgeons around a patient, and one surgeon will go in and he will start the process. They all make a plan. Y'all ever watch House MD? Okay, and they all make a plan on this board, this glass board that they use, and such person would do this, such and such person would do that. They go in as a team, and when they go in as a team, the doctor, from the plan, he would do his first part of the surgery, maybe the first 1 or 2 hours of the surgery. Then the other person would step in, and they would do their next 1 or 2 hours of the surgery. And then you have a third or fourth physician, they would wrap it up. So the initial principal physician, he would be considered full 100% payment. They would take that same surgery code, and I write it on the board about what I mean, and they would use modifier 80, same procedure code, another modifier 80, and they would, use modifier 80 once. Unless if they use modifier 80 twice, 2 more times with the same surgery code outside the first time, then they're going to have to send copies of medical records to state why that has to be paid. Okay, but they would pay the second surgery code with the modifier 80. You would submit that for payment, and then they would pay that, and then you would pay whatever assistant surgeon that assisted on that surgery. Or you may have to split that among 2 or 3 other surgeons. Are y'all getting that? Mm-hmm. And they'll work that out. Okay, that's a whole nother level of accounting. Okay, medical accounting that you have to work out. Okay, but that's what modifiers are for. So it helps insurance companies understand, I'm not just paying for your surgeon and what he did, but he had some help. So y'all need to pay for my help as well as my work. You understand how that works? Okay. So if it's unusual circumstances and you had to have some assistant surgeons using a modifier 80, then yes, they need to pay the whole $400. If it's just the doctor himself, maybe he had the assistant surgeon finish and suture up the patient the last 30 minutes, we just gonna pay you $350 because that's not unusual. Okay. $375. The doctor's billing for $375. Again, usual fee for payment is $350. Customary fee says that, hey, we need to pay $400. Depends on what that is. However, it does not exceed customary level. We're going to pay $375. So they have their variances of how they're going to pay, no more than $400, but no less than $350. So they have those room for reason, if you will. $350, again, the same thing, and then they, may reason out and pay $350. Usual means submitted fee given for service to the patient. Customary in range of the usual fees charged by providers or similar training and experience in geographical areas, such as the history of charges for a given service. reasonable meets the aforementioned criteria or is in the opinion of the medical review committee justifiable considering the special circumstances of the case. Payment is based on the lower of the usual and customary fees. So y'all see how that works out? So it leaves you room for negotiation of how much you want to pay. Okay?
I knew a surgeon that was, once you get to a certain age,
Mm-hmm.
they don't really like you to do surgery. And he was such a good surgeon. The other doctors liked for him to stand in when they were doing surgery.
Yes.
So,
Yes.
I guess that would fit into this.
That's right. That's right. They would still pay him for his knowledge, for his assistance, because he may be their mentor to stand there and say, and because they're still working under his license, and they still may need him for his guidance under his licensorship. He's now a proctor, if you will.
Oh, okay.
Okay, it's just like me, an apprentice in that point. Okay, but he's in a backward kind of way. So he's really proctoring and not being an apprentice, if that makes sense to you.
Yeah.
But what you're saying is absolutely correct. It's absolutely correct. And so, yes, some surgeons, Dr. DeBakey, operated for a long time. Oh,
It's kind of that same situation.
yes, yes. He may delicately did some surgeries, but anything as depth as he used to, I'm very sure they may have said, okay, we got it from here.
Right.
Yeah. But it still had the hands of Dr. DeBakey on it. You know what I'm saying?
So that'll be considered as a modifier?
A modifier 80.
Okay.
Yeah. Yeah. Because he's still useful of knowledge and
Right. He had done the surgeries so many times, the hysterectomies and all of that kind of thing, so many times that, he was an expert at it. So,
yeah. And they could learn from him. They can glean from him. Absolutely. Absolutely. So yes, in those regards, you're absolutely right. So that particular surgeon, he's not retired. He's still working. He just can't work to the capacity, or they're not going to allow him to work to the capacity of that. And so they would pay him on an assistant surgeon level rather than the actual surgeon.
but that would fit into
Yes.
Okay.
They don't allow him because they feel something might go wrong.
Yeah, because a surgeon's hand, their hands have to be still. And when you make those cuts, you better know what you're doing. It better be on point. If you making those cuts and your hands are shaky,
Oh, okay, I get it.
mm-mm. Particularly if it's heart or ventricles or arteries, you want to make sure you don't want to be cutting jagged, and it's supposed to be a straight cut. See, if he's shaking, that's why they kind of examine one another and watch one another, because if he's like this and and I think what you just said, I think that's wonderful that they still honor them to still stand in. It kind of helps with their pride, because you have some physicians, they don't want to retire, they still want to work. They still want to feel important. They want to feel like they got it, but they have to face the reality. You can cost the hospital some money if something goes wrong. Okay. So I admire doctors that can voluntarily step down and say, you know what, this is it. I'm noticing, this is it. I can truly say, like my bariatric surgeon, I give for example, I love him to life, Dr. Garth Davis. He and his dad, they did a show called Big Medicine. You remember seeing that?
I think so.
It's a father-son team. It's a father-son team. And but Garth is my physician. His dad is Robert Davis. And they are just the sweetest, most down-to-earth people you ever want to meet in your life. And let's see. Dr. Garf did my surgery in 2014. I think his dad retired in 2016, but he's still young. I mean, he looks still fairly young, in good shape, but sometimes they just know, hey, I don't want to get to that point where I've got to be forced to sit down. I don't know what all the circumstances were, but he retired, and I thought that was very smart. I thought that was very, because you don't want to be so puffed up with pride and then you have to be told,
Right.
Yeah. So I really admire that. Yeah. I'm 49 years old, so I've already planned my retirement. So I already said, when I get through training y'all and mentoring y'all, and I get ready to sit, I still may do, come in and teach and, okay, let me come see what you're doing. Let me come to your house. You doing some milling? Okay, let me see what. Girl, straighten that up. No, you do that. I'm just telling you how to do it. I'm just telling you how to perfect that. Okay, I'll be doing that. And the rest of my time, I'll be having a prayer line. I have it open for 2 or 3 hours, and after they cut the prayer line off, go watch TV. Because I already know, that's how I'm going to spend my retired time. Yeah.
You gotta plan out.
Oh, let me give you.
Yeah.
Let me give you my address.
Give me your address. Yeah. And me and my best friends, we talked about that. They're school teachers too in the public school system. And I think one wants to. We talked about owning a business together, like event planning and owning a building. We plan parties and stuff like that, and then the other one, I forgot what the other one is. But we already like counting our time, So you have some folks, they, find something else to do, stay useful. Nothing wrong with that. I admire you. Stay useful, So that's where we are. But that's a very good example what you said. I like that example. Okay, now moving right along, relative value studies, I've already talked about that. Resource-based value, I already talked about that. I done beat that over 2 or 3 times. Okay, let's go back, page 157. The calculation here. There's a perfect example. Okay, see that CPT code? The 10060, and the description is for an incision. Okay, remember we learned about suffixes in medical terminologies. Ectomies, otomies. Remember we talked about that? Your incisions, excisions. Okay, so drainage of cyst. Using a hypothetical figure of $153 per unit, this procedure is valued at $122.40. Here's the math. They said, by example, $153 times 0.8 equals $122.40. Okay, so that's just something that those are given variables. Those are given numbers. They may use 0.8 for everything, and they may say, okay, what would it cost in the is California East Coast or West Coast? Is it West Coast? West Coast? Okay. And Connecticut is what? East Coast? I always get that mixed up. Okay. So for all the doctors, what's the cost of living over in the West Coast? I hear that the cost of living is a little bit higher. Loaf of bread is about how much over there in California? About $4.
Their pay is it's kind of the same thing here, because supposedly over there in like a fast food restaurant, they pay them like 15, for example, and right here is like minimum wage $7.25, and it's kind of the same thing. So
yeah, it's just higher. Yeah. So you're absolutely right. So like I think Nature's Own bread. Me and my husband eat Nature's Own, so we probably pay like $2.50, $2.75 for a loaf of bread here. In California, I'm very sure it's probably like $4. Yes. You ever been to California?
Yeah.
Yeah.
I
It's
sure
expensive.
did.
Yeah.
I
Yeah.
didn't much like it, but
It's beautiful. It's very nice. It's just expensive. But you do make the cost of living to compensate for that, you know. So $15 an hour in California is like for us down here in Texas. But when you get
Go
the
there.
bills, the gas,
$1,000.
the rent, you be like, oh, it's about the same down here.
Yeah.
Yeah. Okay. So it's that region. So if all the doctors in this region have to make a certain dollar amount over here to afford what they can live and do over here, and then the cost of living over here in the East Coast is like this, I hear it's just as expensive. I think in Connecticut and Rhode Island and Maryland too. I don't know why it's like that. But anyway, they have to live a certain range, and then the South, we're just a little bit more little less expensive. The pay is a little bit lower, so it kind of compensates. Up north, I'm not sure what northern compensation is. I really don't know what their cost of living is like. I don't know, but they have to meet a happy medium for it to be all the way around. So $153 for a 10060 code is pretty much how can I say usual, reasonable, customary for all 4 regions of the United States. Am I making sense?
Yeah.
So if I pay you 122 in California, you still can make it. Make a good living. East Coast, you still can make a good living. South, you're gonna do good with that. North, yeah, you're gonna do fine. Okay, so that's how they justify that. So let's look at the relative value unit formula. So they have the relative value unit times the GAF. GAF means, is that the gross? Let's see, hold on, let me go back. These accounting terms. Haven't seen that in a while. Yeah, geographic adjustment factor, there you go, times the CF, which is the monetary conversion factor, there you go, the cost of living, okay, equals the Medicare dollar per service, okay? So again, you have to consider the regions, and you have to consider what makes sense monetarily. And then everybody is going to be in a happy medium where everybody can agree to say this is okay to pay. Okay? Now, let's look further down here. Here in this tan box, you have a HCPCS CPT code of 91000. That is a medicine code, okay? And they're going to say, what's the work value of that? 1.04. Okay, so now they're doing the math. Okay, and they're adding all that up, practice expenses, and this is how. Okay, malpractice. You have to consider doctors pay for malpractice insurance. Okay, and this is how they come up with that calculation. So for 2016, the conversion factors for non-surgical care is $36.1096 times 2.03 is the allowed amount for $73.30. Does everybody see that? When we get ready to talk about interpretation of the EOB, we're going to get an understanding how to interpret the EOB. What is allowable? What is an adjustment rate? The adjustment rate is a discount, okay, that the insurance company discounts to not pay the doctor because he's a par provider. I'll explain what all that means later on. Okay. All right. So let's look at the crosswalk here, table 6-2 on page 158. So you have CPT code 99212. That looks like, okay, that's an office visit of some sort. Okay, and they're using the RV value at 0.68. The conversion dollar value says $72.06. The fee is $49. And here we go. The contract conversion factor says $64.71. The contracted fee after all of that would be $44. This is contract payment of 90%, which is 90% from the insurance company. Okay, so 90% of look like it would be 90% of $64.71 would be $44. Are y'all getting that? Okay, so if a patient has a PPO plan and it's a 90-10 plan, the insurance pay 90, the patient pays 10. If it's an 80-20 plan, who pays what?
Insurance
80,
pays 80,
insurance
patient pays 20.
Very good, very good. If it's a 70-30 plan, who pays what? Okay, very good. You ladies getting this. You getting this. Okay. Medicare fee schedule. Okay, we talked about that. We're gonna move along. Blah blah blah. 159. Blah blah blah. Okay, 160. Okay, so here we go. 160. What time is it, ladies? Is it lunchtime? Okay, it's lunchtime. So I'm gonna stop right there on page 160, and then we'll come back where we left off on that. Okay? I'm gonna give you a little snack and take my people.
Miss Paul, when you say HMO, is for people that like go to the doctor a lot, like HMO plan?
That's the cheapest plan. I
It's the
think.
cheapest plan. If you go to the doctor a lot, you can, but it's the
Yeah.
cheapest
I
plan.
was talking to a girl, and they was like, she was saying, I don't know if it's HMO, I was gonna ask, but she was Blue Cross Blue Shield,
Uh-huh.
and she was just basically saying her deductible is high.
Yeah. Yeah. It is for those that go to the doctor a lot.
Cause I remember you were saying something
Mhm.
about, I think you have HMO.
No, she has
I have
PPO.
point of service.
I think it's
Mhm.
PPO.
Yeah.
Yeah. Now, the reason why I say go to the doctor a lot, but I use the point of service plan because I go to the doctor a lot. HMO is good too for those that go to the doctor a lot. The only difference is it's cheaper, but you're locked into certain doctors that you can see.
Okay, so
That's
that's
copay.
HMO. That was
Yeah.
you saying her copay.
Yeah, for copay. Yeah. And you have to see doctors within that HMO plan. Point of service kind of broadens.
I just need to know, because you know it's about to open up, but I'm gonna make sure I get on the right.
Yeah, it's gonna be if you choose a PPO or point of service plan, you're gonna have a deductible. Deductible may be high, but your options are very broad. For HMO, it's kind of narrow, but it's cool for those that have to have that budget.
That's what I was saying.
Okay.
I don't go to the doctor a lot, but,
I mean, it's cheap. I'd rather pay the penalization.
Yeah, you rather pay the penalization?
It's cheaper. Yeah, to be honest, yeah. I figured out my uncle the same thing. He pays the penalization. He doesn't really go to the doctor, so why pay insurance that? He's gonna pay more than the penalization.
yeah, I think I paid a couple months ago. I paid $150, and the doctor's like, you can come and find me to be free. I was living late. I was paying
Okay. Was it just for you or you and your?
for me. I was
Okay.
trying to put my kids on there on like baby Medicaid. I'm like, that's gonna be another extra $100. I'm like, I just put me on there and keep them on Medicaid.
Yeah.
But I kind of want to take because I know we got a good insurance plan with Walgreens. So I'm like, I kind of want to take advantage.
What I've noticed too is that when you have insurance, you pay more than when you don't have insurance. Like for example, if you pay cash, they give you a discount, so you're paying less than when you're
But
paying in
towards the
insurance.
end of the year, my mother-in-law pretty much got all of her money back.
Yeah,
Not
if you
all
put
of
it
it
in
for
there.
paying her insurance. It's just her with no kids. She showed me like her tax thing, and they gave it all back to her
Yeah.
But a lot of what she was paying, she got back in the income tax. So I'm like, it's kind of advantage. It's not a disadvantage if you don't go a lot. But I'm like, hey, you pay it, but at the end of the year, when it's time for taxes, you get it back.
Oh yeah. Oh
You get it
yeah.
back.
Yeah. You do get it back.
Versus not getting penalized, and it's just, she got it back. I think she got like up to, I don't remember, but she's like, that's just from the insurance.
Mm-hmm.
And I tried it. It's like, oh no, you can't get it because you only paid 6 months. I'm like, oh,
Yeah. I mean, I can kind of see both of y'all's point of views or whatever, but I know me.
and then they handle you different. Because I went when I had insurance and when I didn't have insurance. When you don't have it, they kind of like procrastinate. I don't know. I have seen that their expression change. Like, it shouldn't matter. Just as long as I got the money to pay for what I want, just
yeah.
it's like when you have insurance, no matter what it is, they kind of like the office kind of, I don't know, look at you different. You get better services from the doctor and or say, okay, like you say, I'm here now.
Yeah. And that is true. That is very true. I've gone to St. Luke's in the Woodlands, and I love going there, especially when I'm so sick. I go to the emergency room there, and they see me within 30 minutes, But when I saw it, it really kind of startled me. But they have on the doors like insurance or this, So if you have insurance, they put you in the rooms with insurance. If you have
A fee for service.
yeah, then they put you in regular rooms. Yeah. I'm like, oh, it should be the same regardless.
Is your laptop still running?
Huh?
Is your laptop still running?
Girl, show is.
I'm
I'm gonna edit that. Thank you. Thank you, sister. Thank you. Because I'm sure gonna have to edit
Yeah,
that.
I was like, I'm talking. I was like, hold up. Did she press
Pounds? No, I did not. I did not. I can edit it out. Thank you.
Girl, what you're talking about.
Thank you.